I just wanted to make sure. Is there plenty of people signed in online? Are we good?
33 folks.
Oh, yeah.
Wow.
That's good. Good job, guys. Thanks for being here at Alicia Register. For those of us that are here in person in Cordial, I know y'all have been hearing the trains in the background. But anyways, so we've had some really good discussion with the Georgia Trauma Commission meeting this morning, and a really great presentation by Dr. Mapes about the simulation training. And I think we're probably going to talk about that a bit in our meeting today. So thanks for being here in person as well, Erica. I think the QR code was just up there. If you don't mind scanning it to get credit for your attendance, or Gabby, is it also okay for them to put their attendance in the chat? How do you want people to? There's a link in the chat. Awesome. Thank you, Gabby. Okay, so I guess, do I need a motion to call the meeting to order? Or do we just start? Good, okay. You would think after enough of these, I would know by now. I think Gabby had emailed out the July 18th meeting minutes. If everybody's had a chance to look over those, could I get a motion to approve the July 18th meeting minutes?
I move to approve the minutes as written.
Awesome. Who was that? That sounded like somebody online. Yeah. Who was that?
Pender.
Sienna, hey, thank you.
Hey.
What's up? Anybody second it? Awesome. Okay, we got Brooke Marsh from Emmanuel seconding. Thank you. Okay. Liz, do you want to give us some Georgia Trauma Commission updates?
Yes, I would love to give you some commission updates. So for those of you who joined our meeting that we just had, full of information. In fact, I think Terry was saying to me, we all use our acronyms so freely, and they mean so many different things depending on what world and trauma you live in. So at some point, I think we need to break it down, and just so everybody understands the basics of what it is we're actually doing here, because it's almost too much for a 3-hour meeting. We can almost meet for a full day and talk about things. So anyway, please refer to Gabby always does an amazing job posting the commission meeting packet to the website, and it's got a lot of really useful information in it. So please make sure, if you didn't look at it already for the meeting, look at it. The budget is in there. So since we didn't meet in August, please, if you're a level 3 or level 4 trauma center, please be mindful, look at the budget, see exactly what the breakdown was for the for each of the trauma centers, because this is the first year we're at the 3% across the board for 1s through 3s, and 50% for level 4s. For level 4s, the IRR project, it seems like it has, whenever you have an IT project, add 12 months to whatever the time frame is, because it's like turning an aircraft carrier, you know? So thank you to Brooke, sitting right in front of me, for Emmanuel jumping through all the hoops that they had to. I think you guys are probably the only one ready to go for that. But I think what we're going to do, we wanted to kind of get everybody out of the gate the same time, but since different corporate entities have different requirements about getting people access to, it's basically like giving somebody the keys to your Porsche, right? Like, here, go start it up, take it for a ride. So, you know, with all the firewalls and everything, I think we're going to let you guys go ahead and get started since you're ready, but I'm going to talk offline to Q-Centrics about that, because it's like taking so long, and the money is was amended in your FY24 contract, I think. So it's still going to be there. There's no issue with that, but we just want to make sure that we can go ahead, because I'm really curious. We talked earlier about TQIP and the data and data validity, data integrity, and how this is going to be so helpful, I think, to you guys who don't, in centers where you're low resource and you don't have a lot of assets to be able to go behind you and look and see where the coding opportunities are. This is where the rubber really meets the road. And it's going to help us, and it's going to help Gina and Dr. Smith and Dr. Ayoung Chi with the Arbor risk adjusted benchmarking, because if we don't have really high quality data in there, we can't help you figure out what it is you want to look at. And I'm overflowing with ideas of what you could look at, even just resuscitation, right? Like blood products, like who's getting crystalloid, who's getting blood, how quick are people? Let's start with the basics like that. When I looked at Dr. Mabe's slide with even just bag valve mask that like, I mean, that's not just for trauma, that's for stroke, that's for STEMI, right? We've got to have people be able to do these things accurately. So things that we can measure, I think that would be great benchmarking for level 4s in our state, to whatever extent we can capture that in the record. So, so anyway, review all that to say, please look at the packet and let us know if you have any questions regarding anything in there. And then please take, I know it looks like people took them, yay, unless you put them away, Gabby, the annual reports, okay. And we have more coming, okay? So if you need them, we'll ship them to you even, let us know. But our beautiful, shiny new annual report, it's like 3 times the size it was last year. And that's thanks to all you guys and all the great work that's being done across the state. And so very exciting, lots information packed in there. So please take a look at that. There is always a downloadable version on our website. So, so check that out as well. And then I mentioned in the commission meeting that the readiness cost survey for the level 1s and 2s closed in the end of September. We are starting to do validation on that data. The numbers are big, much bigger than they were in our last survey. So I'm really interested to see the aggregate of that. As was, we kind of discussed this, I think, in the commission meeting, but the ACS promises that the level 4 standards will be released in February. I will believe that when the level 4 standards show up in February. So come on, college. I know that aircraft carrier turning is hard. But I'm really excited about their commitment to rural trauma and the development of their rural pillar. They were very interested in Dr. Mabe's program. So I think you're going to see a lot change with education in the rural space. They're basically committing to providing assets and resources around education, around performance improvement, because performance improvement looks so different in the level 3 and 4 centers, just based on what the level of resources, what the issues are, and that, you know, your multidisciplinary peer review committee just looks different. And you know, you don't meet that frequently, right? So trying to get PI loop closure in a timely fashion, I think it's something that we all struggle with. Gosh, you can meet every 2 weeks and still not close the loop on some things. And if you missed it, Lynn Grant brought forward a wonderful proposal for education, and part of that was rural topics. So we will have a rural topic class, and we will have as many people as you need, because we can bump the class number up by just adding additional instructors. So so we look forward to doing that, because I think, again, PI is a little bit different. So I think having assets and resources will help with that. So it'll be interesting to see what kind of toolkit the college puts together to help in the rural environment. And then they're going to have something that they call community of providers. So that is who's taking care of the trauma patients in the rural environment, right? Yes, it's not surgically led, it's emergency medicine, but within that there's advanced practice providers, right? So we have to really figure out how do we leverage those advanced practice providers, because in some communities and practice areas, that's what you get as an advanced practice provider. You may not even see a physician during your stay. So it'll be interesting to see what they come up with. And you know, they know it's a huge focus. And I am fortunate in my role with STN, I get to have a lot of FaceTime with ACS leadership. So I said, you guys have to fill this void, because nobody else is stepping forward to come. You know, it's like the level 4 standards. They didn't really think that they would be needed when they didn't update them with the Orange Book. And then, you know, they're the only ones that really, they know how to write the standards. So. And then, as mentioned today, just from a financial perspective, our super speeder year to date is tracking a little bit behind, but it's not unusual for this time of year. So hopefully that will increase over time. And I think that's it, unless there's any questions.
Had a couple questions, comments, just on some of the topics you just hit on. One is, yeah, PI is so hard when you're at a low volume center, because how do you get loop closure when that may only happen, you know, whether if it's, you know, like a provider thing, then how often does that provider work at your facility? If it's like an ER on their own contract, yes. You know, or like, you know, just anything. If you have a low volume, how do you have timely loop closure? And I don't know, what I have found is with the ACS consult visits that we've experienced, you still have large volume level 1, 2 evaluators evaluating rural, low volume centers. And so it's kind of like we're dealing with different problems. And so it's still kind of like we're not speaking the same language. So what I would love to do or talk to is like maybe the Pennsylvania Trauma Foundation that's already come down, evaluated our level 4s, and maybe they haven't. I'm at a level 3, so I just don't know. But so if any of the level 4s that have done the PTSF visit, I would love to hear from y'all about if there's any discussion or help with like, hey, how do I achieve loop closure? Because one of the main things they said we needed help with, or one of our opportunities for improvement, was PI. So, okay, well, like a mentorship kind of, which I know we do, we have a great thing going in Georgia through this GTCE is like, you know, so I guess I'm asking for the level 4s to pitch in, like what's going on as far as resources to achieve loop closure and improve PI. And if it's not, what do you need? What are some tangible things that we can provide out of this subcommittee? Anybody from a level 4 want to chip in? And this is also something that I love. I mean, I feel like it needs more time than just this 1 hour conversation. So, and we'll get to some of this later on number 7, the kind of realigning our priorities and setting some new goals. This is one of the subcommittee group or workforce groups that we talked about, like PI for these lower level centers. So, but yeah, and again, y'all feel free to reach out to me outside of this meeting, email, phone, whatever, you know, to either express concerns or make suggestions. This is y'all's committee. This is our committee. This is what we're here for, is to have these open dialogue conversations of what do we need help with and how can we provide that. That was kind of my main thing, was like PI at a low volume center.
I can resend that. They did provide for the last round of visits. And if you feel like level 3s would benefit from that, then maybe that's something we should talk about and potentially, you know, bring forward a recommendation, because I think anything you recommend for rural, especially in light of knowing that PI, I mean, the college has identified, PI is an issue for everybody, really, but it's just particularly challenging in the rural environment. But in their report, in their aggregate report, they put one of their opportunities was around PI was limited knowledge of the utilization of the PI module in the registry and report writing, and standardization of software utilization and education on expectation of PI module utilization and report writing. So I think that is big in that, is it that you don't know how to use the PI module, or that you're not doing effective PI, so you don't have anything to put in the module? You know, that could really be twofold. So.
I think Alexis Smith, some of the, you know, is individually going around with Gina to the level 3s and 4s to have those conversations of, hey, with Arbormetrics, like, do you know how to use it? Okay, let's help show you all the different ways you can use it, because let technology work for you. You don't work for technology. So I think the other thing that I was going to ask about, I know at some point there had been a conversation about assisting with documentation and billing being a trauma center versus a non-trauma ER. And there was talk about getting with the TCAA about how can we ensure that we're documenting truthfully and appropriately to maximize our billing as trauma centers. Has there been any headway on that?
Yeah, great question. So I think after the holidays, was our target to kind of re-engage them. If you didn't hear, and you didn't, how many people are TCAA members? Okay, good. So if you're a member, are you guys a member?
I think so.
Okay.
Like looking at Ashley. Yes, I think so. She runs the program.
That's the perfect TMD response. Let me look at the TMD and see what she says. If you're a member, you get a one-on-one consult for free. Don't forget. And I mean, you could do that anytime. So, so I would encourage you in the meantime to reach out and kind of do that. But based on what we found before, and actually it's in the annual report we published, we had to like de-identify it. I didn't want people to be able to see who people were by their volume, because you would know centers like Grady or some of the lower volume centers. But on page 20, the two things that we looked at, which is the capture of the type 5, the patient type for trauma center, and then percent of the sample that had the trauma team activation response actually on the claim. Those were the two things we looked at. And what was interesting is that most people were charging for the trauma team activation response. Very important to make sure that you actually had a response before you charge for it. And then the type 5 was the thing that people struggled with. Now, if you, TCAA just did a phenomenal webinar last week. The OIG did a review of trauma team activations, and it was like, there was like 3.4 billion or something crazy. I don't know if Gina remembers, Dr. Nathan showed a slide, inaccurately billed trauma team activations. And it was anything from, they weren't a trauma center. They did a type 5, which if you're not a trauma center, you can't have a type 5 patient, right? You could have a trauma patient, but you can't bill that as a trauma. So their recommendation was for CMS to go back and try to get all that money back. And of course, CMS said, we're not going to do that. What we're going to do is we recognize there was a failure to educate on how to use the codes appropriately. So yes, we want to continue the education to make sure that everybody understands. Now, one of the little confounding caveats is that Georgia Medicaid has been undergoing a software transition, is my understanding, and not all of their billing codes are compatible with the NUBC, the National Uniform Billing Code. So one of those, and I think Augusta University, they found it on theirs, Grady found it on theirs, is that Georgia Medicaid wouldn't accept the type 5. It was, they would only accept like the type 4, which I think is emergency room or whatever. So unfortunately, you can't use a different patient type for Medicaid than you do for commercial payers. It has to be uniform across the line. Now, I had a contact, thankfully, our other colleagues that we work really closely with, GHA, they connected me with the folks from Georgia Medicaid who said, well, we want to understand a little bit more about this. So we just need to take the next step, which is try to get everybody together in the same room and meet and talk about what this patient type looks like, where they are with their software transition, have they, because there's other known issues with compatibility. So we have that, plus we have the need to have everybody understand what does this look like. So I think we had such great, and the person who did the 2 finance webinars that we've had already, she did the OIG webinar for TCAA, and it was amazing because she's so smart. So if you're a member, you can go back and access that recording, and I would highly recommend you do it because she goes over all the billing things again. Now, she is so smart and talks so fast, and so it just goes like right over my head, and I feel like I have a pretty good handle on it. It still goes over my head. So I think we could probably, and it was so cost effective, I think it was only like $7,500 to have her do those 2 webinars. So I think we could probably take part 3 and part 4 for the spring and do another. Or if you guys felt like it would be beneficial, we had her come back when we were at Barnsley. She came in person to do some finance training. We could certainly benefit. I'm open to whatever the group wants. You guys just kind of talk amongst yourself and make a suggestion.
I think that would be a great thing for us to have a workforce for, and I'll be honest with you, like as a TMD, like that's a foreign language to me. So I'm kind of definitely leaning on the TPMs to help guide these conversations and to even say like, here's the information we need. But just at my own facility, I know something that we have had discussions about is the difference between a facility fee and a professional fee. And so our ER doctors are getting hung up on like, but I didn't actually provide 30 minutes of life-saving critical care. So I'm not going to document that. It's like, well, but like you're in an ER. So I think we just want to, you want to make sure that you're not like fraudulently submitting a charge, but you want to make sure that you're getting credit for being a trauma center. So anyways, I think that that's something I personally, and I think there's a lot of our trauma centers that would like to have some kind of black and white, this is how we should document in order to appropriately submit these charges. And because, the goal is to decrease the amount of uncompensated care that the GTC then has to give us funds for. It's like, it would be nice to be able to have insurance actually pay for all the trauma care. We know that's not going to happen, but if we can at least try to hold them accountable for what they genuinely owe us for the care we've provided, how can we do our part by documenting that appropriately? So I would just like to get a clear answer. I know probably a lot of the other trauma centers would like to get a clear answer on that too. So maybe that's something that we can have a focused group on.
And the activations are only one part of it, then there's if you have an ICU you're admitting patients to, then there's the higher charge for the trauma accommodation code, which Gina did a lovely poster on that she presented TCAA back in her previous life about how to about how to start. How do you track those trauma patients, the number of ICU days, and knowing that that's the trauma patient that should have the higher accommodation code. And I think what I've heard and have experienced is the pushback is always that, well, we've already negotiated our managed care contracts and they're not going to change, we're not going to see this money. You may not see the money immediately, and you'll never know exactly what was paid because the claim just says yes or no, it was paid. I know that's really a letdown, right? You want to see like a dollar amount, but you won't. But over time, just having that activation fee and that accommodation code, according to Val at TCAA, it increases your case mix index. So your reimbursement rates in general will be higher as a result of making sure that you are ticking those boxes for trauma patients. Yeah.
That's great knowledge. And again, as someone clinical, this is like a foreign language to me. So I think between the TPMs and the trauma administrators group, these are great conversations for them to have. Okay, thanks. Anybody else with questions or comments about the GTC update? Anybody online? Okay, we'll move forward. Is Courtney? I haven't seen Courtney here today.
No, he's on vacation.
That's okay.
Yeah.
No, that's all right. Well, tell you what, I know it says March pause update, but Dr. Mabes, would you mind giving here? You want to come up, or I guess the mic's on at the podium, just so the online people can hear. But yeah, just an update or kind of basic explain kind of what we're doing with your SIM program.
Yeah, absolutely. So we're in our pilot year of delivering this rural interactive trauma simulation course. It's a one-day course. It's a portable simulation course. So we're actually bringing all the simulation equipment to the facility. We set up, it's 2 hours of interactive didactics that we have questions and answers, go through case-based scenario, deconstructed trauma scenarios, and then have it coupled with the simulation component in the afternoon, where we're actually going through and teaching all of the life-saving procedures that we talk about in that morning session. So far, we've delivered 4 courses. We'll have 6 total by the end of the year, reaching 10 facilities. And it's been a great opportunity to go out to different facilities, level 3, level 4 trauma centers in rural communities. We've opened it up to allow, whenever we're actually delivering a course, any of the surrounding counties, EMS are also welcome. It's multidisciplinary, so it's for RTs, nurses, EMS, physicians. So really anyone who would be providing care to the trauma patient. So far, we've had great responses. We've been testing medical knowledge pre and post. We've seen statistically a significant improvement in medical knowledge by the end of the course with the post-course tests. The actual surveys that we've done have looked at both their confidence levels pre and post course, as well as their interpretation of the course and how they found the course. It's been overwhelmingly positive. People like the course, the delivery, the speed, the entire format being kind of a combined, morning interactive didactic session coupled with the simulation component in the afternoon. We're going to be continuing this in the spring. We have 4 more scheduled in the spring, but anyone who is interested in trying to bring this course to their facility, I think it's fantastic for any facility and all these different level trauma centers and for all the providers. So, please feel free to reach out to us. We want to continue this going. And if you're interested in being an instructor We also want to be building on this train the trainer model. So the kind of 3-5-year goal for this is that, not only are we going to, smaller communities and delivering this, but we're actually training the trainers. So, it turns into, us training, local providers that are able to then deliver to their outreach communities.
Awesome. Yeah, I'm so excited about this. And it really kind of dovetails with our efforts with March Pause over the last, 5 years, in that we just want to be able to reach out to the farthest most areas of Georgia to make sure that no matter where somebody is injured, they're gonna have those providers and those ERs are gonna be empowered to take care of those in their community. Because let's face it, that's where you're more likely to take care of somebody if you're in a smaller ER. Like, that's your neighbor, that's you know them personally, and that's a lot of pressure, and it's very stressful, and sometimes you can feel helpless if you don't know how to care for them, and then there's that guilt of, did I provide the best care possible? And so if we can really reach out to these farthest out rural communities that don't see bad traumas every day, but hey, when you do, you're gonna have had this course so you can take care of your community and your neighbors and save their life.
I think you bring up a good point too. So I did work a little bit with Courtney on the March Pause, and I think that's kind of transitioned into it. We've gotten the PowerPoint kind of all set, but he kind of described it in a way that's like an introductory course to what it might be, more of a virtual course. And it sounds like this is kind of transitioned into, I think, what people thought March Pause would be or turn into. So this really is focusing on life-saving procedures, and truly like tips and tricks for stabilizing the trauma patient, and how it can be actually applicable. So I think that it's had a really good response, and we're excited to move forward. So yeah, anyone who's interested, please feel free to reach out. It's for anyone and everyone, and we're just going to keep rolling with scheduling facilities.
Awesome. Thank you so much. I'm excited you're here in person and we get to meet and share ideas. So seriously.
Can we get a goal for all the level 4s to
I think so.
That was our original goal with the original March Pause course,
I think it's definitely doable. And the difference is they have the manpower with their fellowship program. They have all the sim equipment. They've got the brains, the leadership behind it. So they definitely have a more organized push. You do it in January. Awesome. Emmanuel County's doing it in January. So yeah, no, I would. I hate to.
Dr. A, you're going to be an instructor now. Sorry.
She signed you up. Well, so I talked to him on the phone. He called me for a transfer, and I was like, by the way.
Yeah, that's how you can. Yeah. Hey, I'll accept this patient if you agree to host him. Off the recorded line. No, that's funny. No, I really think it'll be beneficial. Yeah, I think that's a great idea to take it out to all the level 4s. So yeah, we can definitely talk more about that.
We don't need to make it like a contract situation. Let's just let's have it be a friendly.
Yeah.
A friendly.
She and I talked on the phone. I was like, this sounds so much like March Pause. And she was like, yes. I was like, Courtney's from here. This sounds very
similar. You always have to pivot.
So the premise is the same, just a little more advanced. So we're excited.
Yeah. Good. Yeah, me too. Awesome. Okay, so then on to number 5, the PTSF consult visit and the ACS system consult rural focus review. So I think we kind of already touched on some of this. And really, this is an ongoing effort, I know, Nita Ham, you had done so much help with getting a 96% survey response rate on it. That's like insane for surveys. So we really appreciate your help in getting that strong response. And
I did not earn the nickname, Nita the Nag.
Hey, sometimes you have to have that constant awareness of what you haven't done. I hate to put you on the spot, but do you have any updates? I know you and Damien had kind of said like, hey, we'll bring this forward to like the rural GHA. Has there been any more conversations as far as presenting this data to those that are kind of like on the administrator side or like leadership of hospitals?
He's supposed to be online.
Who?
Damien is supposed to.
Oh, Damien, are you online?
I don't see his name.
Okay. Well, if not, has there been that presentation? I know there was some meeting that y'all were gonna present this survey response
I think
to.
he probably was for GHA, but I don't know.
Okay, okay, I got you. Well, we can always, again, this is something that's been ongoing. And really this dovetails into the survey we sent out and went over back in July to the 3-4 group, like, hey, we've done all this amazing work. We did the readiness cost survey for level 3-4. We were the first state in the whole country to have readiness costs financial information for lower level trauma centers. So we don't want to lose that momentum. And so, we had sent out a survey about what do our new objectives need to be. And we had talked about PI for lower level centers. So that's something we already brought up, is like, how can we be better at PI and loop closure? And there was a lot of response back from trauma program managers about being involved in that work group. Another work group that we had talked about was like transfer, inter-hospital transfers. And another one was how can we start utilizing like teletrauma to reduce the number of transfers that actually need to happen. There has not been a lot of volunteer response on those. And I'll be honest with you, I don't know, y'all know me, I speak candidly, but I'm a TMD. And I understand as a TMD at a lower level center, like it's really hard to carve out the time to, to put anything else on your plate. Cause this isn't the only role that you have at your hospital. It's actually a very small role you have probably among all the other things you're responsible for at the hospital. And so, but we really need to hold ourselves up to the responsibility that we've accepted when we're TMDs. Dr. A, thank you for being here. You're always here. I love seeing you. But when it comes to clinical projects, it's definitely obvious there's not as much involvement. And Dr. Pender, I know you're online, so I don't want to leave you out because you're always, present too and eager to help. So I really appreciate that. But we really, and I need to do a better job as the chair of this committee, reaching out individually to the TMDs and saying, hey, what do you need? As a clinician, as the TMD, how can I serve you better? But definitely there's a noticeability, and as far as physician involvement, whether it's the March Pause courses, there's like rarely any providers that are there as participants. It's mostly nurses, paramedics, respiratory. And I guess what I'm saying is we've got to make time, because we're never going to move the needle on anything clinical if we don't. And a lot of it is knowing how to ask for help. I think that's a struggle I have, is knowing how to ask for help. I feel like I need to be able to do it all. I should be able to do it all, but I can't. And so, I want to be a resource for the TMDs out there. I definitely don't want to put anything more on anybody, but, as far as clinical projects go, we've got to be involved too as TMDs. So I'm going to throw that out there as well. So as far as these other workforce groups that we decided with the survey were important, we need the people to be able to lead them too. So, and that, again, just to recap, is more with the teletransfers or like teletrauma stuff, so we don't have to transfer. And then how can we improve our EMS transfer availability in those resources?
Damien's on the line now if you want to re-ask.
Good. Hey, Damien, are you there? Maybe.
I'm here.
Yes, now I can hear you. Sorry, I'm sure that was loud. Hey, we were talking about the ACS systems consult and the rural focus group survey. Sorry, I took my glasses off for a second. Remember the survey we did about the demographic survey and the non-trauma center resources? There was discussion that we were going to present that to the rural GHA and kind of present those findings to like the higher ups in the state that can actually make decisions. You mind just giving us an update on that project?
Yes. So I don't have that. Help me remember.
Yeah, no, you're good. I know it's been a while. I think it was like, gosh, what, even 2 years ago? Because I remember standing in the driveway of the like rental house we were living in. So I can remember, it's been like
While
2
your
years
house
ago.
was being built.
Well, my house, yeah, it's been like 2 years. So it's been a while, but again, this is a slow moving project. It was an important project. So it was a survey that Nita Ham had really helped with the State Office of Rural Health.
Oh, we
push.
presented it last year, just this time last year.
You
we
pres-
presented it.
Yes,
Do you
okay,
remember what survey? There's a lot of surveys, so it's hard to remember which one.
yeah, and I think she presented that to the GHA. I have an expanded role in GHA and I'm willing to continue to bring these issues forward. So just as this group feels like, if there's something that we can bring to the hospital association, I'd be glad to do that.
Yeah, I think, so a survey that we sent out amongst the level 3-4 subcommittee during the summer, and we got those results back, was basically agreeing with the survey results from that survey was EMS shortages and how that affects our ability to transfer patients timely to the right center, and equipment in these smaller ERs, education, training. We're trying to address that with the simulation projects that Dr. Mapes was talking about earlier with AU, and kind of combining those efforts with March Pause, so we're not kind of working in silos doing the same thing. But yeah, so it's like we're all saying we need the same thing. So all these surveys that we've sent out, no matter who's responsible for sending them out, all say the same thing. So I think that's where we just want to form some workforces on actually moving the needle on those projects.
So Dr. Register, this is Damien again. And of course, this is just their application, but there's some things I think within the state's application around the rural healthcare transformation program that they applied for the HR1 dollars that are going to be coming down into the state. I think there's some things that will help the trauma system, dollars that'll help the trauma system that are in that proposal. They haven't heard yet whether their proposal's been accepted and how much money they'll get, but there's pretty strong indications that at least it'll be 100 million, probably more than that, and that they'll be able to fund some of these projects.
And what part of the state, like what state office is that going to be through again?
That'll go through the State Office of Rural Health, which looks like that's where you are right there. I think that's who's going to manage it. In their application, they list that they're going to have to staff up a little bit to make that happen. But I think for us in particular around EMS and maybe some workforce things can help the trauma system kind of boost up a little bit.
Yeah, that's really good news. I mean, unfortunately it always takes money to do anything. So that's
Yeah.
good to hear.
Liz, I'm sure you guys have seen that application. If not, yeah, you have. I can see your head. You're the only one I can see, by the way.
Who? Okay. Yeah.
The Pearl Street. I'm not asking for much.
Awesome. Thank you, Damien. I really appreciate that. I really appreciate just all your effort. I mean, you're one of the faces that you've been here since day one and before me. And so I just always appreciate your willingness to help rural hospitals and rural trauma. So thank you. Let's see, the Trauma Connections Group update. Is Rachel or Christy on the call?
It's me, Christy.
Hey.
Hi. So over the last couple months, what we kind of talked about, and if you aren't familiar with what this is, it's just a group of us. There's mainly trauma program managers. Sometimes we have some registrars or some PI people that attend also, but it's a 30-minute meeting once a month. And we just kind of bounce ideas off of each other, or if we have any of those kind of dumb questions that, you don't really know who else to ask. And a lot of the ones or twos don't really understand what you're asking because they're, at a whole nother level than what you are. But the last couple months, we've talked about kind of the organizational structure and the recommendation, because there's, of course, we're still in the Orange Book, so there's not a lot of guidance on you should report to this person and then directly over here. So we kind of discussed that at one of the last meetings and who we report to, and then that direct report to the trauma administrator, also the dotted line over to your trauma medical director, and then holding more than one hat, and kind of how that looks like in other facilities. We also talked about Qcentrics. As far as I know, with everybody who has attended, I'm the only one that's up and running at Morgan with this. So I've kind of been giving a little bit of the feedback that I've gotten from Dawn, who is the person at Qcentrics that has been doing the reviews on my records. A lot of it was just very simple changes for me to make, which was like not putting NAs on a couple things, but actually going and changing those answers to none, things like that. So I had given a little bit of feedback on that. Also, several people have started up the matter of balance, and looking for when the bingo size will be introduced as far as injury prevention. And then discussion on report writer and some of the queries that, like, some people have some options that other people don't, and how some of the reports look like when they spit out, like the expert report, how that one looks a little like kind of wonky, and it's not really great useful data when you run that report and you send that in on your quarterly report to the state. And then the last thing, the big thing, is PI. Yesterday we had Mary Beth from Archbold give a demonstration on how she uses the ESOV5 PI module. Next month we're going to have Tammy from Liberty do a demo on how she was using the image trend PI module. And then out of that, it looks like a couple of us discovered that we don't have all of the tabs and the buttons that we think that we are paying for, but we don't actually have access to. So I had actually sent Gina a message this morning about with some screenshots on how to look into that.
Yeah, I think, there's so many different electronic medical record systems and so many different systems between like EMS and trauma centers and this and that, I know you can't have a monopoly and only use one thing everywhere, but sometimes it would be nice. So,
Well, this is the registry, if I'm hearing you correctly, Christy, so she should have the same tabs that everybody else has, so.
For B5, it's a little, you have to pay for the outcomes module.
But
Well,
it's
we did-
supposed to be included with the registry anywhere, and I have already, and I went back and clarified with the emails that we were sending back and forth back when we did this. I've already emailed Danielle, and she said it should be hopefully a permission issue. They're working on it, Christy, so hopefully.
These are the little things
That's
that
what I'm
are
saying,
huge
so-
impact that
Yeah,
we
so
don't know.
yesterday, when we were sharing, when Mary Beth was sharing her screen, and everybody's like, wait a minute, ours doesn't look like this. It's just when you get down to that little level, that's when you start.
And you wouldn't know that if y'all didn't share screens.
Correct.
They don't know what they're missing. So-
Correct.
no, that's a great point. Yeah, and that's like the whole, like, you don't know what you don't know. Like, you think you're looking at the same thing, but yeah. So, Christy, is there any suggestions or recommendations that, in regards to anything that we can do to help, I don't know, figure out other loopholes like that, like we wouldn't have ever known without, like, or that's something y'all can talk about in that meeting. Is there anything that you think we need to do better at or do more, or that we might be missing?
I think I think it's a good start.
Mhm.
Just, I think this has opened a door.
Yeah,
And so now we'll just keep digging
Yeah.
to see what else we find.
turning over rocks.
That's right.
Could we, or would people be interested in, I thought I took all these screenshots of Dr. Nathan's his like opening presentation was so good. Definitely, it's worth a listen when it comes. Unfortunately, they don't release it until like January.
Mhm.
But this piece around rural community of practice, I texted Kelly immediately. I'm like, we need to start a Georgia Rural Community of Practice Council. We need to do case reviews, because if you don't share with each other, you know, I mean, I just don't know if like our GQuIP meeting's the right venue, because it's a lot of level. I mean, what happens in rural is so specific and so different, and you could almost take it through all the way to loop closure with the people who are having similar cases. So,
Well,
Yeah.
and I think too, in the GQuIP meeting, I think it would, and I know you can't share specific MR numbers and you have to figure out a way, but even showing once you do the case review and let the physicians think through their part, let the PI or the TPM see how it's documented loop closure wise in the record, so that when ACS come, you know, we're all on the same page.
Mhm.
Because that's what we discovered yesterday in that conversation is, you know, the registry is designed to be yours. So you use it to the best that functions for you. But as people were talking yesterday, there was conversation, well, I don't do it that way, I do it this way. And people were bouncing things off each other. And I think that was huge. It was good to listen to.
Yeah, all really good points. Maybe there's something we can do, you know, with our peer review. I mean, we all have to have our peer review meetings, you know, tend to do them with our quarterly reviews. So I don't know if there's a way for us to be able to collaborate with other hospitals. I know that's sticky from a legal, you know, but those meetings are protected, kind of like why GQuIP is a closed session, is because there's protected patient information, but that way we can openly talk and have real meaningful conversations. Yeah, so yeah, that's a great suggestion. Okay, let me put my glasses back on so I can see the screen. So, you know, we've already kind of throughout this meeting been talking about the level 3-4 committee priorities. And so again, PI, we've got a lot of support and volunteers to do that. But then the transfer, like your resources, and then the tele-trauma consults to decrease the need for transports. You know, again, those are kind of the two that I think they're important, but we really have to have the people to want to, you know, help. So again, email me or Gabby. And I don't know, I'm like looking to you because I don't want to be the one solely responsible for, like, I don't want to be the only one that gets the memo. But yeah, either email me or Gabby, and that way we can then kind of get a list of people. So again, the three main ones is PI, which we had a lot of response and enthusiasm behind. And then teletrauma, how can we collaborate with our receiving facilities to maybe avoid some unnecessary transfers? And I know whenever I talk to somebody from a level 1, they're like, yes, let's do it. This is awesome. And then that's as far as it goes. And because again, it just takes that's a big thing to buy, you know, that's a big bite to chew when you're talking about 2 hospitals sharing patient care. I mean, we have tele-trauma, we use tele-neuro, there's tele-psych, there's a lot, I mean, like Dr. Hess at MCG with like the stroke, you know, like tele-stroke, I mean, that's huge throughout the state. And so we really need to catch up with that as far as trauma care goes. And I think it's possible, but again, I think it takes people that are willing to volunteer their time, put their heads together. And I think it's gonna take from a trauma administrator's standpoint, as far as getting hospitals to agree to work together and share some of the, you know, whether it be liability, documentation, how do we show that we really are appropriately and safely managing the patient? So I would really like to see personally that project move forward. And then the other one is EMS, you know, transfer, inter-hospital transfer. How can we improve that? I think what we agreed on was it was one, manpower, you know, shortage in people, but then also training and education and maybe some of the like the post certification, like what they're allowed to do. I mean, like, great example. I had a patient penetrating injury to the groin, vascular trauma, had to be, for different reasons, had to be ground transported up to Grady. The guy was gonna need blood en route. So, but I had to have a nurse go in order to spike more units of blood. The guy ended up getting 7 units of blood just en route alone, not what we had already given him. He made it. I mean, he got up there, you know, with a pulse, so that's a win. But, you know, but no, really, like, so these are things that are real that we really need to talk about, and whatever we can do to help decrease the red tape and just do what needs to be done to take care of the patient. You know, I think that's what we're all here for. It's just somehow it ends up in all the steps to get there cloudy. And so I really appreciate everybody that consistently comes to these meetings and is really, you know, doing their best to what do we need to do to take care of the patients, no matter where they get injured. So I really appreciate y'all. Okay, anything else on old business? Any questions before we move on to new business? So new business, I mean, again, like I said, I need help. You know, no one can do it alone. I also think that it is healthy for an organization to have multiple people that know how to do the job. Because if something happens to somebody, you know, just like, I mean, can you imagine if your TPM had to be out, you know, for FMLA, like the trauma program would essentially stop moving forward. So, you know, like it's good to have multiple people that can step in. So what I would love to see is kind of a rotation of leadership. And that way you're also not doing it alone. Like when I had Greg, it was great because, you know, we could, hey, are you available to make this meeting? No? Okay, I am. And so we help each other out. But you know, I feel like it's made me be a better TMD and have a better realistic understanding of what are the issues, not only at my facility, but at other facilities that are like me. And so what I would like to see is having kind of a like chair, co-chair rotation, maybe like 2 years each, you know, and that way you kind of have as a co-chair, like, or like vice chair, 2 years to kind of like get your feet wet, see how it's done, get used to it. And then you do the chair for 2 years and then, you know, you get a break, you rotate off, and then maybe a few years later you come back to it, you know? So if there's anybody, I already have some ideas of mine that you know, if you get an email or text from me, you know, after this meeting, but if you're interested as a TMD, and really something we had talked about, it really doesn't have to be a TMD. Like, let's face it, the TPMs are the ones that really run stuff, right? We just kind of sign off and agree, yeah, that makes clinical sense. So, well, some of us have talked and we think it would be very appropriate for not to only always be a TMD that's the chair, but a TPM. I mean, shoot, sometimes maybe even a registrar that really knows the system and really involved. So we are totally open to ideas and suggestions. But I need help. And I would love to build a strong group of leaders that can continue to run this group. Again, I think it just makes us a stronger group to help, you know, continue the trauma efforts in rural Georgia. So if you're interested or have questions at all, please reach out to me, either email or text. Then I think the last thing on the agenda, because it's basically 2 o'clock, is oh, it just switched to Christy Bath. I don't know what the last thing was. That it was about the budget. Huh?
Proposed meeting dates.
Oh, yeah, that's easy. That's, basically, Gabby's got it up on the screen. So, January or all of them are, Zoom, virtual. And then this is the only one that's kind of, option for in-person. But, always good to see people in person, especially when we go to the meetings. Like, I guess our next one is, up in Atlanta, Emory in February. So always good to see people, talk to people in person. I feel like that's when some of the best conversations and networking happens. All right, guys. Well, I appreciate your time. Anything else?
Motion to approve.
Yes, can I have a motion to approve the dates? Anybody can do it.
Move to approve the dates.
Yeah.
Great. And then we've got a couple seconds in the back here. Ashley Billington, there you go. All right, thanks, guys. I think that concludes the meeting. Bye.
The podcast again, you and
I
me?
guess.
Oh, man.
Just like
It's like a
The last time I
podcast.
really, it was like, yes, Liz,